Also, I would like to express my sincere thanks to my all panelists, those who are joined, Asim Sukla and Pramod Reddy from the USA, and Professor Ansari from the SGPGI Lucknow, and Dr. Professor Amilal Bhatt from the Jaipur. So in next 30 minutes, we are going to discuss, we'll try to discuss a couple of cases related to the pediatric urology. And to start with, this is the first case. This is about the 6-month male child. History of recurrent febrile episodes in last 3 months, but never investigated for urinary tract infection. And at the time of last episode of urinary tract infection, last episode of fever, he was detected with the urinary tract infection. And it was confirmed on culture. Urinary stream of patient, according to parents, good, non-circumcised, creatinine normal, and they were not having any knowledge of prenatal urinary tract issues. Of course, we went ahead with the ultrasonography. It shows at renal level as well as bladder level hydronephrosis nephrosis and a slight increase in echogenicity of the cortex, but corticomedullary differentiation well maintained.
Now we are
see very well in these pictures. So with this, I would like to put the first question to Professor Amilal Bhatt. Sir, with this history and sonography finding, what will be your next investigation?
I think next will be VCUG. And before VCUG, I would like to have, if I have the sonography to be seen by myself, I usually prefer to see the sonography, especially the posterior urethra and the vesico-ureteric junction nicely, tracing the urethra.
So I give you the details. Posterior much because of spillage of contrast in the urine. With these two images, are you comfortable in making diagnosis, or you would like to have something else in your mind?
No, I would like to have. I would like to have, and especially the urethra part. I am not very comfortable with seeing. You see, if you see this much part, this part is somewhat dilated. So I think if we have
the dilatation, sir, doesn't. Do you think that this means what you are suspecting in the urethra? Are you suspecting PU wall?
You see, I have a suspicion of both PU wall and if there is a dilatation of the urethra distal to that one, that is one of the causes of dilatation to the posturethral valve, and another may be that sometimes maybe anteurethral valve also. So I have to see nicely before putting on any remark on this one, a good delineation of the urethra in full length.
Fine. Yeah. But I went ahead with the kind of a diagnosis of a primary vesico-ureteric reflux of high-grade dilating reflux, and with that I put the patient. I treated the initial infection with the culture sensitivity antibiotics, and then subsequently I put the patient on antibiotic prophylaxis. And after a month, we wanted to study that how much insult is there with the kidneys. So we went ahead with this DMS scan. And Professor Ansari, I would like to request you to read the DMS scan on benefit of the viewers. What is your interpretation on this DMS scan, sir?
If you see on the posterior projection, there is some evidence of photopenic areas in both the poles of right and the left kidney. If you see, especially in the upper pole here, in the left kidney also, as well as in the right kidney also. But as such, the morphology is not that much altered. Yeah. We can see that it is a much affected secondary to pyelonephritis. Perfect. As well as the function is also very well preserved, 53 and 46% on each side.
Perfect. And there are no dysplastic changes.
Yes, as well.
So
because
do you think that together with this VCUG and DMS scan, you are agree with my diagnosis, presuming that this is a case of a primary high-grade vesico-ureteric reflux with couple of episodes of febrile pyelonephritis, but now the patient is starting stabling on the medical management.
Can we go to the VCUG for a second? Yes. So if you see on the right side, bladder is pretty smooth. It does not show any irregularity as well as evidence of the trabeculations. As well as the posterior urethra is decently seen. It's not very distended also. Anterior urethra is very well filled and seen. The only problem is that the radiographer did not tilt the table slightly, because in infants it is very difficult to get an oblique projection. It is the radiographer has to tilt the table to get the exposure of the posterior urethra. Otherwise, the slightest doubt of posturethral valve, which Dr. Bhatt is saying, would have been alleviated.
Perfect.
But still, my first bet will be for the primary reflux rather than anything else.
Okay.
With UTI.
So I continue with the medical management, where I put the patient on antibiotic prophylaxis. Constipation was avoided. Preputial hygiene was addressed, and there were no episodes of breakthrough febrile urinary tract infection. Child was gaining weight and height, and urine no pus cells. We kept on a 3-month follow-up doing urine routine micro. This is the last urine routine micro I wanted to show that was done at 1 year, and creatinine was also well maintained. And with that, we did at the end of 1 year another sonography, and these are the sonography pictures where you can see the dilatation of at renal level. Pelvic LSL dilatation reduced. Slight echogenicity is there, which was there in the previous USC, and you can see at the bladder level, certain level dilatation of ureter reduced. So Pramod, I would like to ask, you really agree with the diagnosis which I made and the treatment till now, or you are thinking in different way?
No, I think that your diagnosis is pretty accurate, but could you go back to the VCUG for a second? There are a couple of points that I'd just like to share with the audience. And that is that, we have to get in the habit of looking at all of the information presented to us. I know sometimes because of the brevity of time, we like to show pertinent images, but to me, it's always important to look at a post-void image on a VCUG. With regards to Dr. Bhatt's concerns for a obstructing process here in the urethra, one clue that tells me that maybe we don't have a urethral valve is that when you have a urethral valve, the caliber of the urethra distal to the obstruction will always be narrow. It won't fill up like this. Yeah. Because it's taking away a lot of the kinetic energy of the urinary flow, so the urethra won't get distended. But you can see here, his bulbar urethra is nicely dilated. Yeah. So I would have less suspicion of valves. I also agree with Dr. Ansari saying that on this image, the pre-void image, the bladder looked nice and smooth. So again, it's not a trabeculated bladder. My concerns are that when I look at this image, one, the bladder looks really large, right? So I think we have to be careful with these children. He's too young to do any sort of real active bladder management in terms of time voiding and double voiding. But there are instances where when you have a pseudo PVR that gets rather large, that the bladder will get over distended. And so that's...
Now, what you would have advised as such at that particular juncture, Asim, how you would have continued further treatment in this child after a year, once the child was already stable?
Yeah, I mean, I think, the care was excellent. The diagnosis, I agree with. I think, you asked about dysplasia. I think he had some dysplasia. Those upper pole lesions were not necessarily from pyelo. He might have been born with that as part of the whole complex of high-grade reflux with dysplasia. But anyways, that's elementary. It doesn't affect your management. Management has been perfect. You can go back to that VCUG. You've got that VCUG at 13 months. Not you did, they did. My own feeling is I usually wait till about 18 months. There's some very good data that at around 18 months, Ulla Sillen's data from Europe, from Sweden, showing that the bladder pressures diminish at around 18 months. Until then, they're quite high. And it's also because Yves Honzi had shown that the urethral sphincter, in the beginning, it's more like a circle. Later on, by around 18 months, it becomes more like an omega. And that allows the pressure in the urethra to relax and the bladder pressure is reduced. And so oftentimes high-grade reflux improves. So for me, 13 months is going to look the same. So I tend to just say, stay on prophylaxis, 18 months, we'll repeat a VCUG, and we'll see where we are.
Okay, so you would have continued the management till 18 months.
Yes.
And maybe you would have thought about the repeating the VCUG at that particular time to see that what exactly the now grade of the reflux or what
Right.
the bladder.
And then you can decide, do you need prophylaxis?
So now, see, when they went to the another setup, Asim, they felt that probably in the previous VCUG, the treating urologist missed the PU valve probably, and that what they mentioned into their notes, and then they repeated the VCUG. These VCUG pictures are in front of you. This is little much better than the previous VCUG. Would you like to now make the diagnosis based on this VCUG? Or your diagnosis is the same?
Yeah, I mean, I think my diagnosis is still the same. I don't see any posterior urethral dilation. I don't see any trabeculations in the bladder. I'm not worried about an obstructive process. He has high-grade reflux. Those ureters are a bit tortuous, bulbous, but he voids nicely with a small PVR. So I agree with the diagnosis. Yeah.
So, but as per your comment, you are not agreed to do VCUG at this particular 13th month period. So, and the diagnosis also you are okay. So with this, they felt that there is a still possibility of valve. So they went ahead with the cystoscopy, and according to them, there was a valve. And they fulgurated at 3 places. They put a catheter for 2 to 3 days, and the patient was discharged, taking out the catheter. This patient appeared again to me in the last week of the December, that is 3rd week post-operative, with a sepsis and very much in toxemia. Patient was now very much sick. I have to send the patient to the pediatricians, admission, IV antibiotics, culture, and all those things. And VCUG picture was taken after 2-3 days of the patient bit stabilized. So what do you think, Asim? What could be the reason for this sepsis? Is it a post-operative event, or it is just how to explain?
So, we did a study when I was in Minneapolis looking at all antegrade hydronephrosis patients. We repeated a study at CHOP as well. And when we look at antegrade hydronephrosis, antenatal hydronephrosis patients, the number one risk factor for febrile UTI was having a catheter, having an MCU, having a VCUG. The point is that when you put a catheter, and more if you do a cystoscopy, you're putting this child to risk. It's not a benign procedure to put a catheter in, to put a cystoscope into the urethra and examine a bladder when you have high-grade reflux. So I think, 3 weeks, it's a little bit long, but it could have just seeded, the bacteria could have been seeded, and then you ended up getting a full-grade pyelonephritis. So I just don't think, or they've created an obstruction. We don't know. They're doing the valve, quote unquote valve ablation. They might have actually strictured the urethra, damaged.
This patient is with you now. Again.
Yep. So I would sit down with the family and say, it's unfortunate that he had an UTI after the surgical intervention. He continues to have high-grade reflux, poor emptying of his dilated systems. That right side after the infection looked like the left side got much more, the ureter dilated even more. And Chris Cooper from Iowa has shown that while we tend to focus on the degree of hydronephrosis, in patients with reflux, it's actually the ureteral dilation that has got more prognostic indication. And so with that ureteral dilation, I would say that he still has clinically significant and relevant reflux. But based on how he did before, he did really well on prophylaxis. I would say, let's just give him some more time to grow. There's very good data to suggest that even boys with high-grade reflux will tend to resolve it as they grow and their bladders go through the changes that Dr. Shukla was mentioning. The bladder pressures change, the sphincter changes. They tend to have less of an overactive bladder as they get older. So I would just kind of give them
adding alpha blockers? Sorry, any thought of adding anticholinergics?
Oh, no anticholinergics at this point, and no alpha blockers, because if you look at the previous
do you practice any anticholinergics in this type of cases of high-grade dilating reflux anytime?
I do if I think that they're having very high pressure and they're emptying their bladder all the way. But right now, I wouldn't do anything else. I would just kind of watch him.
According to you, what are the chances this patient likely to land up with the need of a bilateral reimplantation?
Still too early to tell. I would like to reserve that opinion until he's around, until he's toilet trained, and see how he's doing. And what I would tell the parents is that if he gets another UTI, febrile UTI, gets that sick, then I would probably recommend some form of intervention besides just prophylaxis, whether that's surgery, whether it's double prophylaxis, whether it is doing a vesicostomy. I think these will all be on the table if he gets another febrile UTI. But right now, I would just say continue prophylaxis.
So it's a very good discussion, I think. And Professor Ansari, I would like to request to conclude this case very in a brief manner, listening all this.
Yes. Oh, yes. This interesting case takes me back to my residency days, and where I heard the diagnosis of overdiagnosis. And I was told by my professor that overdiagnosis is the side effect of screening. And we were discussing the CA prostate that 20 years before. And because you are diagnosing a case of CA prostate, which would have not caused any side effect on the patient's life. In screening means you are finding a disease which is clinically insignificant. And posterior wall in pediatric urology is another example of overdiagnosis. Many centers which are not doing a regular practice of pediatric urology, lack of training, basically results in this kind of overdiagnosis. And most of these, with due apology, I'm saying this urologists and many of the pediatric surgeons, they overdiagnose and they cut some subtle mucosal pores in the posterior urethra, which is a normal finding in many infants. We all see such kind of things.
5-month male child had a very boggy hydronephrotic kidney where uretropelvic junction obstruction was very much proved on all the investigations. So pyeloplasty, Anderson-Hines pyeloplasty was done before 4 weeks, means at the age of almost 4 months. And the 3/14 stent was inserted across the anastomosis in antegrade method, as we all do most of the time. Renal pelvis was 40 millimeters, just to give idea how big was the pelvis, with central and peripheral calyceal dilatation, with cortical thinning. Stent position was confirmed on table and was taken for stent removal at the end of 5 weeks. So, and to my surprise, this was the situation at that time. The stent was completely migrated into the kidney. There was complete proximal migration. Even the lower end was there in the calyceal system. So I tried with the 4.5 semi-rigid ureteroscopy under the fluoroscopy, but I could not see the stent. And
yeah, it happens. Yeah. It happens. There is and especially if you are using the smallest size of the stent, and when you are putting in, it will be better to put in when you are fixing up during pyeloplasty, fix up and put the DJ stent upper coil in the lower calyx. That will one of the tricks that can prevent larger size.
Okay.
That will be a better
less
one.
likely that it migrates.
Yeah.
Now, Asim, I know your practice. You use percutaneous removable stents across the anastomosis most of the time.
Not always. I do I do like internal stents actually, and internalized stents. It depends on the family. You're right. On babies, I use external, internal, the Saleh stent. But in this situation, I've had this happen. All of us have. What I have found easiest is to just perk and remove it, because you have a pretty large pelvis, I think I've done that, but in this situation, but I should say that that's because I have an external internal, so I have a track. In this situation where you've got complete, I think I would do what you have done, which is put a stent.
Still, I still agree that there was a really good option was there. Only thing that I never talked about this option to the parent, and my anesthesiologist was also not prepared at that time. We thought that it's a very small procedure, take it and take out the stent, and by evening, the patient, after 5-6 hours, patient will go home. But even it is reported that the chances of a couple of days of urinary leak higher with the no stent cases. In that circumstances, how you explain the parents, because in my practice, I find it very difficult, because most of the time nowadays patient wants to go quickly home. They don't want this kind of a leak there, having a drain for long. Generally, when we put a stent, we don't keep a drain. So, Pramod, let us start with you. How you explain, and if suppose there is a long duration of keeping the drain, I sometimes get a call from friends that my drain is there. I have not put a stent. Now, what exactly I have to do? Whether I attempt putting the stent, I'm fearing that I may further damage the anastomosis. So, tell us about your experience, Pramod.
So I think that for us now, our cutoff is, and this is only with our robotic cases, the babies are usually about 6 months and older. If we've done a robotic pyeloplasty, no stent, no drain. And I think the reason is that with the magnification that we get with the robot, we are doing much more robust of an anastomosis. You know, when I do an open pyeloplasty, I'm usually putting 8 stitches around the circumference, 6 o'clock and 12 o'clock, and then I do 3 on either side. And I would typically place a stent. But with the robot, I think we find that we're doing, and Nasimba, you can chime in, but I think we tend to do a few more stitches, and so we get a pretty watertight anastomosis right away. Our failure rate, and we just published this, I think that we had out of 50 patients, we had to go back in and put stents in about 3 or 4 patients. So it's been pretty successful. The benefits are that it avoids a second operation to go and take the stent out.
What were those incidences? What were the reasons for that? Urinoma formation or sepsis? Why you
abdominal distension, pain, and then we went back and put up stents in these patients, and so. But most of them were still in the hospital before when they were diagnosed as having an issue. Decreased urine output and abdominal distension were what happened in 2. One of them went home and came back with a febrile UTI, and we had to put a stent up in that patient. But again, we've been pretty lucky, pretty fortunate that whenever I'm putting a stent, I put a three-way adapter on the Foley. So when I'm ready to place a stent, I tell my nurse to go ahead and clamp the Foley. We fill the bladder with methylene blue. And so when the stent goes in, you'll see the blue coming up alongside the stent. That is very reliable as long as the patient does not have coexisting reflux. If they're already refluxing, then that doesn't help you. But
I didn't follow your advice, Asim. I was in position to do work, but I didn't explain that things. I not expected. So at that particular moment, it came in my mind that I have a flexible. I'm doing a good number of retrograde procedures. So let me put another stent in a retrograde manner and wait for 2 weeks. There will be a good dilatation. I will be able to put a flexi, and I will be able to take out the stent with the flexible related piperonge forceps. And when I took the patient second time, I was shocked, not surprised, but I was shocked seeing that the second stent is also lying completely into the pelvic acid system, which was beyond my imagination and explanation. And that particular moment, I went outside. I called the parents. I told them that the only option remained with me is this, that I will make a small puncture. I convinced the anesthesiologist, and we turned the patient in prone position, make a small puncture, did only 10 French dilatation, used the smallest implants. So as we have to go a couple of times to remove the 2 stents, so we used the 10 French implant sheet, used the pediatric small size ureteroscope, and remove both the stones successfully. But it was very painful experience for me and for the parents. So do we have 3 quick questions? How you decide, Professor Ansari and Amilal Bhatt, regarding your stent size, diameter as well as the length in the kit in infants?
The stent length, we all know it depends on the age of the baby.
For example, most of the time now
we all know. The caliber. In pyeloplasty, most of the time we prefer this thinnest stent available. Because this is not a matter of pyeloplasty. If you recall, because there is some problem sometimes the BUJ also. and you fail to cannulate the BUJ if you are putting a 5 French or 6 French stent. So I personally prefer to put a 3.5 or 4.5 French. And I have seen that larger the size of the pelvis and the SFU grading, more the chances that you will have relative resistance to the BUJ. Guide wire goes, you will never get an absolute obstruction, but a 4 French stent usually does not go. So 3 and 3.5 French. In pyeloplasty, I prefer. Length, we all know it depends on that.
Yeah, 3 French is small, maybe. We use 3.7 is what Cook makes. So 3 French is very small. Maybe the baby has bladder spasm, small bladder, or pressure builds in when he voids, and this thing pushes up. It's hard to know, but clearly you have something going on that caused it twice. I think it had to do with the size of the stent, maybe too small of a stent, and the voiding. So interesting, but difficult. I can only imagine that had to be not a happy moment when you saw the second stent had migrated.
Yeah, Amilan Bhatt, sir.
Yes, what the explanation which came to my mind is that if it is in the upper calyx, the coiling in the bladder is small. The peristalsis starts from the calyx itself. So if it is a bogey pelvis, then and the ureter is also dilated, then there are more chances of, with the peristalsis, there is more chances of pulling that up. And once that starts moving, and if some uncoiling, you see, if it's a full coil in the bladder, then it will stay. If little bit uncoiling, it goes up, then it is a more chances.
So this paper is agree with your this particular theory. So last message from you, mini PERC or retrograde attempt.
Before PERC and retrograde, I will just suggest you might find a surprise also. For my sake, please do a VCUG. If you get a reflux, we have seen those ureters which are refluxing, they also have a upward migration also.
Okay.
So this because there is a conduit all the time which is going. And secondly, migrations are also seen in pelvic kidney. The commonest migration in our patient in the pelvic kidney because they are also most of the time refluxing kidneys.
So because of
time constraint,
I have not shown the another case which I faced before 8 months. Pelvic kidney,
no problem.
Complete migration of the stent. I agree with you.
Yeah, so reflux may be one of the region which may transfer the stent from lower story to upper story. And secondly, regarding your question, and obviously, if I am there, so I will first try to, if it is lying into the pelvis, then what Dr. Bhatt and other have told, rigid ureteroscope can do and solve the problem. But
that I tried.
Like in your case, then my first choice will be flexi if that fails the PERC. In the same.
Thank you very much. I really thanks all my panelists to join. In specific, Dr. Asim Sukla, he joined on his birthday. Yeah. So very precious time. He allowed.
Happy birthday to you.
So, yeah. So we on behalf of all the USI members, we are wishing you a very happy birthday.
Thank you.
Thank you very much, Professor Pramod Reddy, Professor Asim Sukla, Professor Ansari, and Professor Bhatt to join in this case discussion and enlightening us. Thank you very much, and hope that we'll get more and more such opportunity to interact with you. Thank you very much once again.
Thank you, Dr. Anil.